Bom, boa tarde, good morning, good afternoon.
Good afternoon. It's a great pleasure that I start today the international series of webinars, starting with the topic, the use of self-test in fighting COVID. This event is the result of a big effort that the London School of Hygiene and Tropical Medicine and International Diagnostic Center is been doing and promoting for a while now. In this sense, LDIV, the Latin American Alliance for the Development in Vitro Diagnosis, with FIND, the Foundation for Innovative Diagnosis, got together and had a wider discussion, and with the support for the COVID-19 Convergence Project, the MDRC, that has the support of USAID and ANS. There are a lot of partners, CBDL in Brazil, and AudMed in Latin America, the Alliance for Medical Devices. All of them with the same goal of bringing more tools in fighting COVID. COVID that is a ghost that's hunting us for more than 2 years, that killed a lot of people. So for you to have an idea, Brazil recently released in the Institute for Research a report that shows that in 2 years, from 2019 to the end of 2021, 4.4 years of life expectancy of the Brazilian people. So that before was 76.6 years, it dropped to 72.2 years old. This is scary. It's going to bring huge impacts for economical activities, for retirement, and we're going to have a lot of issues regarding economy, social areas, and other consequences. A lot of births were delayed, pregnancy that didn't happen, and all of that, also the chronic disease that were not diagnosed or were not being monitored in the proper way. The diagnosis market needs to be available for the population in the different fronts. And this is going to allow us to get a recovery. COVID as a pandemic didn't end, and now we'll debate in this first session, and we are going to continue on day 7 next week, the second session, with a lot of experts from around the world that will bring their view, their experience, the technical view and experts to add value in this fight, in this moment. And I will end my thinking that we need to get your attention. It's not because we are not using masks that the other proper cares shouldn't be done. The 2 for diagnosis is important. We have 1.6 million cases of contamination a day, against a peak that we had 3.8 million in January, and an average below 892,000 infections during the 2 years of the pandemic. So the problem is still there, and we have new variants that are appearing all the moment. So the first session, I will invite Professor Rosanna, that's professor and director from the Diagnostic Center and Research from the International Diagnostic Center, and London School, Hygiene and Tropical Medicine, that it's going to do the first presentation. In here, that was the key that was missing, the use of self-test in fighting COVID-19. So Rosanna.
Thank you so much, Carlos. And I really like to say that this has been a really productive collaboration that we had with you in the last 10 years in terms of doing these series of international webinars and seminars and workshops in order to tackle the issues about diagnostics at whatever time it was in the topic of global health. And here today, I just want to start by putting into context the use of self-tests in the fight against COVID. And here we have just from the 27th of March, where we are today with regard to the pandemic. And you could see that in essence, this has been a very, very long pandemic. Most of us in the beginning thought it would just last one season, and that by the summer, the whole thing would be over. Little did we know that 2 years later, we're still trying to control the pandemic. And so just in the context of how to use diagnostics during this pandemic, we've really evolved to our thinking around what we know about the virus, since this is a new pathogen. Now, at the very beginning, when the Director General of WHO, Dr. Tedros, started to announce that this is a pandemic, he did also say that he urged countries to test, test, and test. And he said testing, isolation, and contact tracing should be the backbone of this pandemic. So you could see on the right-hand side, many countries have set up special testing centers, either as temporary tents or actually special places in the hospitals for testing. And so in terms of the use of diagnostics in the first place, we wanted to use it to confirm the clinical diagnosis of symptomatic individuals. But at the same time, because we know so little about the virus, we wanted to use diagnostics to look at refining the case definition for COVID, and of course, testing of contacts to interrupt transmission, and enable research to determine the mode of transmission, the speed of transmission, and monitor whether any interventions work or not. But very soon afterwards, by March and April of 2020, we know from contact tracing studies, from case histories, that asymptomatic individuals can also transmit in the community, as well as pre-symptomatic. That means before they become symptomatic, people were already shedding virus and therefore able to transmit their infection to others. So with that, the entire premise of using testing only for symptomatic individuals has now gone by the wayside, because we now know that studies show that between 14 to 50% of infections in communities could be due to asymptomatic or pre-symptomatic transmission. And with that, some countries consider mass testing, more consideration of using less expensive or less demanding tests, such as antigen detection, in order to try to screen for people who may be at risk of acquiring infection or transmitting an infection. And at the top of that list would be people who work in hospitals to care for COVID cases, or people who work in elderly care homes who may be putting their care home individuals at risk if they are positive. So it's really important that we think of, in the first instance, only using molecular tests to confirm cases, but then with the second phase, when we know about asymptomatic, pre-symptomatic transmission, that's when we first thought about using simpler tests that can be accessible in communities to screen for population at risk. And then, of course, with March, a lot of countries started to lock down. And so testing for travel, it becomes very important. And testing for travel at that time usually is only restricted to using molecular tests, because they're the most sensitive. But some countries where molecular testing is hard to come by, or that the results way too long, some countries would allow antigen testing. Now, as the epidemic went on, in that same year, we now know that they're starting to be variants of concern. At first, they were variants of interest. We're watching how well they develop, but then it became very apparent by September of 2020 that there are a number of variants that are very efficient in terms of transmission, and also the speed of transmission became very important. And so when you see, for example, the Delta variant that was first detected in India, we could see that rather than having an incubation period of 7 days or so, where you could see that, you know, you do have that time for contact tracing, you no longer have that luxury. With the Delta variant, I remember the public health in Singapore, they looked at their contact tracing records for the Delta variant, and they could see that there were 3 generations of transmission within as short as 10 days, which means that the top-down approach to using identifying cases and contact tracing are now no longer possible. So with that, we come into the phase of the epidemic where we started to look at variants of concern, how to monitor these variants of concern. And because vaccines have become available, maybe testing of individuals would be less in demand as we ramp up a vaccination. But nevertheless, vaccines don't prevent infection. They prevent the hospitalization and they prevent deaths, but they don't prevent infection. So we do have a race to try to keep up with the variants of concern. And that's when many countries started to think that self-testing has to be the option, because top-down approaches for tests and contact tracing are no longer possible. Now, so one of the first countries to approve self-tests is the United States. So in November of 2020, the US FDA granted the first emergency use authorization to the first COVID home test. And in January of the next year, the White House put out a statement to say the testing is an important tool to help mitigate the spread. And that the CDC has recommended the use of at-home tests if people begin to have symptoms or are gathering indoors with a group of people who may be unvaccinated or at risk of severe disease, such as those who are immunocompromised, etc., or have underlying comorbidities. Now, to date, in the US, the FDA has granted EUA authorization for 15 rapid antigen detection tests and 3 molecular tests as home tests. And they're widely used and they're available from pharmacies and from testing centers. Now, in the UK, in December of 2020, the UK approved its first COVID self-kit. And then in March, the UK government decided that employers in England will be able to offer free rapid tests to their staff to take home to test. And that's because if people are positive, but they have to travel to work to find out that they are positive, then they've already infected people that they are in contact with on public transport, going to work. And then they still, after they test positive, still have to travel back home. So the wiser thing would be to offer the free test for staff to do at home their tests before they come to work, and only come to work if they're negative. And so that was offered on the 28th of March, and quickly 60,000 companies have signed up for this workplace testing. But then by April of 2021, the government has decided they will give access to 2 rapid tests a week from that Friday for everyone, and that the test would also be freely available and for free at testing sites, pharmacies, and throughout the post, the mailing system, if you want to request it. Now, interestingly, in April of last year, the health secretary said that this will help squash any outbreaks as lockdown eases. But critics of the program said it risks becoming a scandalous waste of money. So I think that everybody has a different opinion about self-tests in those early days, about a year ago. And what is it today? So today, here's something from the UK Health Security Agency. And they showed in numbers how many tests have been used since the beginning of the pandemic. But of course, that's not only self-testing, but there are, to the right-hand side of that picture, is 7 million tests available through their home delivery channel every single day. And so that's in the UK. And when I was last in London, I see that people test as part of their social lives before they visit the elderly relatives, before they go to a club, or after they come back from a club. And they freely share with others their status. You know, if they tested COVID positive, they were not hiding the results. They share it with their friends and say, sorry, can't over tested positive, etc. And so this has become part of their social fabric right now. And in fact, we went to visit a friend, an old friend from Canada. And when their son came home for Sunday dinner, their son had to be tested before he could sit down for Sunday dinner, because he goes clubbing with his friends, and his parents were concerned that he would spread the infection. And so that's become part of our normal living. Now, as to whether people actually upload their positive results or negative results to the government website, apparently only a small fraction would do so. Now, in the rest of Europe, starting from March of last year, the European CDC already published a statement to say that self-tests improve the accessibility to testing and support the early detection of cases and can reduce the risk of community transmission. And they said now that at that time, they wanted to say that shifting the responsibility of reporting test results from health professionals and laboratories to individuals could lead to underreporting and make measures such as contact tracing, quarantine of contacts more challenging. Now, what they didn't say was that actually also the quality of tests and quality of testing has to be considered, and also the risk of positive and false positive and false negatives. Now, in the following months, in April of 2021, the Swiss government decided that rather than leaving it for the individuals to try and seek the tests, self-testing online, because there are a lot of very not very good tests that are being sold over the internet. And so in order to control the quality of the tests that people use for self-testing, the government decided to allow everybody to obtain 5 self-tests per month free of charge from a chemist. And so in a way, try to control the quality of the tests that people use. Now, in Singapore, and Singapore being a small island nation, has a very tightly controlled epidemic. And they first approved their self-tests also in May. And now 16 different test kits have been granted emergency use authorization. And also in August of last year, every household in Singapore was entitled to self-test kits. And the the Ministry of Health actually said, and this was reported in the Straits Times, which is the major Singapore newspaper. As Singapore, the Ministry of Health said, as Singapore gradually transits to being, being a more resilient nation, and the society will have to play an important part in managing the pandemic, which is a concept that many of us are starting to realize that in the past, when we talk about public health, we tell the public what needs to be done. But in this pandemic, we realize that a new definition of public health has to be that we empower the public to, with the knowledge and the tools, to do their part in the public health response to a pandemic. And that's really important. And we could see this playing out in some countries better than others. And having that personal responsibility for your health status and the safety of others around you is something that I think most people would take seriously, and therefore self-testing can be a viable option for pandemic response and control. Now, to date, there are over 100 countries that have approved self-testing. And we could see that you could use this test as a test to protect the vulnerable, as a test to release from quarantine or self-isolation after testing positive, as a test to stay in school or workplaces, as a test to enable the resumption of mass gatherings and travel in order to allow the economy to recover, and also a test to empower individuals to take responsibility for their own health and take a part, an active part in the public health response. And of course, underlying all this, as I've said before, our concerns are the quality of the tests that they buy, being given the tests, the quality of the testing. Even though many test kits come with video instructions as well as written instructions, but there are still concerns about whether there are mistakes made and whether those mistakes translate into a wrong test result. And I think this is something that would be discussed later. And then there should be risk mitigation strategies for false positive and negative results, reporting of cases. How do we do that now with self-testing? There's fear of coercion and unintended consequences. But I think that these concerns will be addressed by the WHO guidance on self-testing, which will be the next presentation. So thank you very much for this opportunity. Thank you.
Fantastic, Rosanna. I do appreciate your kindness and always being present, especially when Brazil is concerned. We have been counting on you for all these years. Thanks a lot. I'd like now to invite Dr. Gillian Sacks. She's an immunologist with expertise in infectious disease diagnostic, product development, introduction, uptake, and scale up. She's currently a technical officer in WHO's COVID-19 health operations laboratory team within the health emergency program. Gillian, thanks a lot for accepting this invitation. We are honored to have you here, and please take the floor.
Thank you so much. Can you confirm that you see my slides in presentation mode? Great.
Yes, perfect.
Well, thank you so much for the invitation to join this webinar today. I'll be providing a little bit of an overview on the self-test guidance that WHO released about 3 weeks ago. So as a bit of context, obviously since the start of the pandemic, WHO has been releasing guidance and operational materials to support SARS-CoV-2 diagnostic testing, recognizing that timely and accurate testing is an essential part of a comprehensive COVID-19 response strategy. This started back in early 2020 with the release of our first guidance on laboratory testing for SARS-CoV-2, which really gets into the details on the different technologies available for testing. Later in 2020, we first released interim guidance on the use of antigen detection tests in the diagnosis of SARS-CoV-2. And that guidance was most recently updated in October of last year. We also have guidance on how national programs can consider setting strategies to guide their testing programs. And all of this is underpinned by supportive materials, including implementation guide that was developed as a collaboration between FIND and WHO, as well as 2 open WHO courses, one that gives an overview on antigen rapid testing for SARS-CoV-2, and another that specifically talks about implementation of these assays. And then, as I noted, our most recent guidance was released about 3 weeks ago on the use of SARS-CoV-2 antigen rapid tests specifically for COVID-19 self-testing. We also are trying hard to digest and simplify our somewhat dense guidance into infographics so that we can enable support for testing at both the individual level as well as at the community level. And I've included links here to several of these infographics. So I will note that obviously throughout this pandemic, there are different waves and different forces of infection that are driving changes in testing rates. And each country is really facing a different situation at different times. And it requires being very agile and thinking through how you implement your testing strategies. As the pandemic continues and the virus continues to evolve, we recognize that policy adjustments will be needed. And so we try to make our recommendations and our guidance to be flexible so that it can be adapted as per national context. So when it specifically comes to the use of antigen tests for COVID-19 self-testing, this guidance was issued by WHO on the 9th of March. It is similar to other WHO guidance. It is driven by the evidence. And our guideline development group specifically focused on the fact that there's data to show that users can reliably and accurately self-test, that COVID-19 self-testing is acceptable and feasible in a wide range of settings, and that it may reduce existing inequalities in testing access. We recognize, though, that self-testing is only one option, and therefore this guidance is meant to be considered in conjunction with our other guidance, especially our most recent guidance on the use of antigen RDTs by professionals. The intended audience for this guidance document are policymakers and others who are responsible for planning and implementing SARS-CoV-2 testing, especially in low and middle income countries. And we are working to make derivative products that would be more targeted for the public who would be end users of self-tests. So the recommendation that was set by our guideline development group is that COVID-19 self-testing using SARS-CoV-2 antigen rapid tests should be offered in addition to professionally administered testing services. This is a strong recommendation, meaning that most countries should adapt and adopt this policy. And it was based on low to moderate certainty of evidence. In the guidance document itself, and I have the link here for you, we make remarks specifically around human rights, around the evolving epidemiology and context in which self-testing would be implemented, highlighting the need for national programs to think about how to prioritize this intervention and the appropriate messaging that should be used given the local context, as well as the need to continue to monitor the accuracy of self-tests as well as other tests as new variants emerge. There's also implementation considerations specifically touching on results interpretation, messaging and support that should be considered by national programs, service delivery options, as well as reporting. I'll just highlight here the different evidence sources that were used for this guideline update. So there were 2 systematic reviews of the preprint and published literature, one on the accuracy and reliability of self-tests, and the second on the impact and utility of self-testing. We also commissioned a global survey of the public on existing policies and extent of implementation. And then we also reviewed data from a UNITAID and FIND supported feasibility and acceptability study that took place in Malawi and Zimbabwe, as most of the published literature comes from high-income countries at the time. Finally, we reviewed survey responses from the general population, healthcare workers, and potential implementers of SARS-CoV-2 testing across 8 low and middle income countries that was conducted by FIND. So some of the key points from the guidance is that self-testing will need to be adapted to the national priorities, epidemiology resources, be that financial as well as human, and the local context, and that this should really be with input from the community in which the testing is meant to be implemented. We recognize that the populations that may benefit from access to self-testing will vary widely by setting. And so it's really important that programs and implementers review their national context and that community engagement happens so that there's appropriate participation and planning as part of these rollout of these interventions. We also note that self-testing really should always be voluntary. And it's important that in certain settings, such as schools and workplaces, that the costs of self-tests are not borne by students or workers. Clear messaging is really needed so that users understand when and how to self-test, what the meaning of their result is, and what they're supposed to do following a positive or negative or invalid result. Finally, we note in the guidance that self-testing can be considered both for diagnostic as well as screening purposes. So what this means is that depending on the epidemiological situation, someone who is symptomatic or someone who knows that they had a recent exposure to SARS-CoV-2 because perhaps they're a contact, they can consider a positive self-test result as a diagnosis of SARS-CoV-2 infection and should link to care and access to therapeutics as appropriate. Self-tests can also be considered more for screening purposes. This would be for someone who may be asymptomatic, who has no known exposure to the virus, but maybe just wants additional reassurance that they are negative in order to engage in a particular activity. In that context, you might want to consider confirmatory testing for a positive result because the positive predictive value may be a little bit lower. In the guidance, we do include implementation and monitoring considerations. And I will note that WHO and FIND previously released implementation guidance specifically on SARS-CoV-2 antigen detection rapid tests, and many of the same principles that are considered for the rollout of professional antigen tests are applicable to the rollout of self-tests. We note that self-tests should meet existing standards for professional use antigen RDTs, meaning they should be at least 80% sensitive and at least 97% specific when compared to a nucleic acid test comparator. And we also note that in the studies that we reviewed, many of the self-tests meet the sensitivity requirement, especially among symptomatic individuals, and exceed the specificity requirement. So they have at least 99% specificity or higher. We note that it's important that storage, operation, and disposal information needs to be provided, and it should be possible to throw away self-tests in the general waste system. It's important to adapt existing quality assurance procedures so that they can include self-testing kits. As Professor Peeling noted, we want to ensure that the quality of testing, even though it is by the general public, is maintained. And that it's really important that resource requirements and systems for the procurement, the distribution, stock monitoring, consumption tracking, et cetera, of self-tests needs to be considered as part of overall testing systems. And as noted previously, programs should review the role of self-testing within their overall programs and adjust implementation and messaging as needed. We also noted that there are digital tools available to help capture test results or enable reporting, but these need to really be appropriately planned and adapted to the needs of end users and may or may not be appropriate in every setting. There's additional context in the guidance noting that while data visibility may remain a limitation of self-testing, the increase in access may far outweigh that concern. So I will just also note that we have more and more therapeutic options becoming available for COVID-19, including oral antivirals, which are starting to become recommended and available globally. Many of these need to be administered early following symptom onset, and so increasing timely access to testing is really essential. And hence the use of antigen tests by individuals through self-testing, as well as by trained professionals within the healthcare system, really can improve early diagnosis and earlier access to the clinical care pathway. When it comes to improving access to reliable and affordable tests, we note that self-testing really provides a way for people to test and make personal risk decisions. We recognize that there is increasing availability of these self-tests, but in many markets, these remain in the private sector, and hence prices remain out of reach of most, especially individuals living in lower middle income countries. In order to address some of this, WHO has now opened our emergency use listing procedure to review self-tests. I've included the links here where you can see what the requirements are. And hopefully this will facilitate access to quality assured and high performing self-tests in the global market. I will note that WHO has been a bit slower in coming up with our guidance related to self-tests, and hence our pre-qualification colleagues are using an abridged assessment for products that have already been approved through the EUL procedure for professional use, or products for self-testing that have been approved or authorized by the US FDA, Health Canada, or the Australian Therapeutics Goods Administration in an effort to hopefully enable expedient approval of self-tests through the emergency use listing procedure. I will finally note that one of the sources of information that we used to set this guidance was a global survey. In that survey, we found that over 100 countries are already either implementing self-testing, piloting self-testing, or are in the process of developing supportive policies for the use of self-tests. But we did note that the reach of self-tests seemed to be already greater in high-income countries than in low and middle-income countries. And we're hoping by having this guidance, we can help facilitate a more equitable balance in accessing self-testing. Many respondents reported that self-tests are distributed through pharmacies and retail settings, in addition to community settings and other clinical settings. There was high willingness reported to use self-tests across all 6 WHO regions. And as already pointed out by Professor Peeling earlier, there are many self-test products available, many of which are of questionable quality assurance or regulation status. And this supports the rationale for why it is critical to enable WHO EUL approved products. So I think with that, I will thank you very much for the invitation to present today. Back to you, Carlos.
Thanks, Gillian. It was great. I have one question before passing to Cheryl. I realize you have already printed and actually distributed a PDF version of the English guidance. Are you preparing a Portuguese and Spanish version, or would it take too long? And if so, could we start working on a non-official Portuguese and Spanish version here for Latin America?
So we are in the process of translating the guidance into all 6 WHO official languages. Portuguese is not one of those, Spanish is. But we will work with our PAHO colleagues likely to have a Portuguese translation, but if we have any issues with that, I will follow up with you.
Yeah, no, that's great. Count on us for facilitating and expediting that.
Perfect.
Thanks a lot,
you.
Gillian. I will now ask Cheryl Johnson, Technical Officer in the Global HIV, Hepatitis, and STI programs, working on self-testing for over a decade, covering guidelines, country support, and research, to conduct a debate. a discussion with you, Gillian, Rosanna, and all the other speakers that are here are free to take part as well. Cheryl, you have the floor, please.
Excellent. Thank you so much, Carlos, and thank you, Rosanna and Gillian, for great presentations. I really want to, encourage folks to write any questions they might have in the chat so we can, take those forward in this session. But one thing I wanted to ask both of you, at the beginning of Rosanna's presentation, she talked about the early advice from Dr. Tedros to test. Given where we are in the current, pandemic and with the self-testing guidance now out, what do you think is really the best way to operationalize that advice with what we know now and where we're headed in the COVID-19 pandemic and with self-testing? So I just want to open it up with what your thoughts are now moving forward.
Gillian, you want to go first or shall I?
Please go ahead, Rosanna.
Okay, so Cheryl, thanks for that question. It's very important because many countries are now thinking, okay, if people are not ready to report or too busy to report or shy to report their either positive or negative results, then it would be difficult to know where we are with regard to the pandemic and when is it ending, right? And so many countries have switched now to relying more on wastewater surveillance to look at how communities are doing in terms of having traces of the virus in the community. So for those who are not familiar with wastewater surveillance, it's actually looking at sewage, and looking at whether there are fragments of RNA still left. So it could be a long tail of positives, but I think over time, you may be able to see a trend of decreasing viral load in sewage, which means that as a community, the pandemic is receding, right? And so rather than relying on case detection, the way that we've been doing, waking up every morning and looking at the numbers of cases, we can no longer do that, okay? And so that's another alternative. And it's the evolution of testing strategies as we are now facing. Gillian, over to you.
Yeah, thanks, Rosanna. I agree wholeheartedly. I think there's two aspects that are happening here. I think testing remains really critical for giving visibility into the evolution of this virus globally as well as locally. But as Rosanna points out in her presentation, testing is also becoming part of personal choice and empowerment. And I think as we move forward, I think it will be up to countries to figure out the right mix of ensuring that testing is accessible to anyone who needs it, but also maintaining appropriate surveillance so that we can ensure that medical countermeasures are available to those who most need it, so we can adjust our public health and social measures as needed, et cetera, and be as agile as possible. So I think it's overlaying that baseline surveillance where we want some level of representativeness of high quality testing, whether that's through wastewater surveillance, whether that's through sentinel surveillance, et cetera, and then also enabling individuals to have choice in accessing testing so that they can engage in activities as appropriate and then seek care as and when necessary.
Yeah. And this would be more important in cultures with multi-generation homes, right? That individuals would want to ensure the safety of their elderly that are living with them. And so those are part of the personal choice and protecting vulnerable individuals in the community.
And also, if I may complement, we have also the issue of first stopping the circulation of the virus, so as early as possible to interrupt the disease to be continuing. That's one. And second, really to promote the early access to therapies. That's a very important thing. So some people in a large country like Brazil, 8.5 million square kilometers, not everyone has immediate access to a lab or to a hospital. They would take long time to get there. If they have available a self-test, they immediately know, and through telemedicine and other IT technologies that we have now available, you can really secure a kind of therapy for that person.
Mm-hmm. Yeah.
And Carlos, just maybe to follow up on those really helpful remarks and insights, particularly with Brazil, when you have a municipality, driven kind of health system with different policies in different locations, when you think about the applicability or what it's going to look like now to implement testing and self-testing, what is the mix of public and private sector engagement that you see, and what kind of actions are needed at the global, regional, and local level to support countries like Brazil around testing?
Yeah, fantastic question. Thank you, Charlie. What I see is that you must have a combination between public and private, first point. Second, even within private or public, you must have also a combination of the different tools that you have available in diagnostics. So we're talking about professional RT, PCR, professional rapid tests, antigen, eventually antibody, and especially the self-test. For instance, in a small community where you have an outbreak of COVID, it doesn't make any sense to keep people waiting hours and hours online there outside a building in order to get a test, to have a test deployed. And that's exactly the image we saw, its reality in January. In January, Brazil had an outbreak, a combination of H1N1 or H3N2 plus COVID. So many cases, and were one or the other. And people were looking for labs, public or private, and were standing in line. That's summertime. So it was going to rain anyway. And most people would or go back home, give up testing, which is a problem, or would all go inside in a small facility, all breathing the same air, which is probably going to mean that they will, if they were not, they will be contaminated afterwards. So that's a very good example where a public officer responsible for the healthcare of that small community could, for instance, ask everyone who has a doubt or a situation that they want to check, that they would take one self-test, go home and do themselves, and they would report afterwards or would have access through, let's say, as I said, telemedicine or any other kind of technological support for clarifying doubts. So I do see a need for a wider consideration in this kind of solutions. And unfortunately, in Brazil, and that's going to be a topic today, self-test is not yet that much seen as a public healthcare tool. It should be reconsidered. Some cities are considering, most of them are not. The Ministry of Health is still not very certain if it should or not be part of the program. It's part of the program, but they are not going to procure. So that's a point to be considered.
No, excellent. Thank you so much, Carlos. And maybe to reflect on the global, to go to you, Rosanna and Jillian, now with the WHO guidance being out, what do you see as the next step for countries, drawing from what Carlos is saying for Brazil, but also for other regions, when we think of Asia, Africa, Eastern and Central Asia, Eastern Europe, Central Asia, the Americas more broadly, maybe what your reflections here would be very useful to think about. What priorities do you see?
I like to think that now that WHO has issued the guidance and are trying to engage more manufacturers to have the test pre-qualified or have EU emergency use listing, is that with competition, we could put the prices down, because I think a lot of people would self-test if the price is affordable for them, right? And given that they could be freely available, but maybe not affordable. I always speak about the 3 A's of accuracy, affordability, and accessibility. So here we're increasingly seeing accurate tests we're increasingly seeing accessible tests, but the affordability question is still not resolved. And I think WHO can do a lot to help with that. And you know, from working on the HIV self-testing, that actually WHO's effort in that was just outstanding. So I hope that this can be done again. Over to you, Jillian.
Yeah. Yeah, and I think what Rosanna mentions is very important. And one point I wanted to make or highlight from the overview that you provided from how other countries have been using self-tests is we really see that self-testing is becoming quite normalized, and it's in many countries it is not stigmatizing. So people are comfortable testing, they're comfortable sharing their health status with their friends and their community members. And I think that's a really unique context here for COVID-19, which is not the case with some of the other disease areas where we've seen self-testing be really impactful. So if we can kind of capitalize on that empowerment aspect and the fact that testing is viewed in a positive light, I think that can really help public health agencies as they're trying to use self-testing as part of their overall arsenal. I think, as Carlos, you pointed out, if we restrict this to only being in the private sector where people can buy these tests if they want, I think it would be a missed opportunity for public health programs. And as you point out, as part of outbreak investigations, as well as to preserve their national systems, because I think right now SARS-CoV-2 has really taken over most healthcare systems. And by using self-testing to complement your existing diagnostic systems, you can now go back to diagnosing all the many other infectious diseases and non-communicable diseases that continue to spread and have even been negatively impacted throughout this pandemic. So I think some of that messaging is really important, and we're hoping then that member states can adopt and adapt these recommendations to suit their individual populations, because it is complex and we need to be cognizant of that. But great question. Thanks, Cheryl.
No, great. And just to push a little bit deeper into this affordability question, you know, I don't know if there's fine colleagues on the line who, you know, Sergio or Elena or Sanjel or others who want to speak about some of the projections around what they're seeing for costs, but that may be useful context. But, you know, maybe a question just for Gillian and Rosanna might be, you know, what are your messages to donors that might be asking about procurement? You know, Global Fund, PEPFAR, you know, have historically procured in the HIV self-testing space. Global Fund in particular has C19RM funding for COVID-19 commodities. Is there a role for donors to play, or do you see this as more of a private sector domestic funding space?
Cheryl, I think it's a mixture. I actually see, you know, many countries are now realizing that they don't want to be reliant on somebody else, right? They want more ability to manufacture themselves. And actually the partnerships that have already started in Africa and in Latin America with companies that are already making these tests, and to make them I guess diversify the manufacturing sites so that you have more low technology transfer and local production in different parts of the world. That would make the accessibility and affordability question can be tackled at the same time. And that I see as a more important way to do it than to just donate tests, right? And we've seen this also for vaccines, even though manufacturing of vaccines is much more complicated than manufacturing of rapid tests. And countries or actually donors have started to support manufacturing of vaccines in different regions of the world, right? So I think that's an important approach that donors and others are taking. Over.
No, thank you so much, Rosanna. I don't know, Gillian, if you want to add, or maybe just seeing if there's anyone from FIND who wanted just to give some context around the current pricing or some of the projections that might be shareable for this workshop.
Sure, I'm here, so I can give a little bit of of insight. So I just want to agree as well with the not underestimating the importance of the local manufacturing. So we do have a lot of Fine traditionally had done a lot of work to secure some pricing, the pricing that manufacturer controls. So that would be the pricing from the factory. And then to that pricing, you have to add the pricing of the shipment and the price, the import taxes. And of course, that actually could add almost as much as the test cost itself, right? So all these prices are all these additions are not there if the test is produced in the region. So it makes a lot of sense. But however, we do see a lot of a tendency towards the price decrease. So we see the rapid test became much cheaper compared to where the prices were 1 year ago. So consequently, from the last year, we've made a number of contracts with the manufacturer with the price commitment, so the price from the factory around $1 to $2. So the cheapest one, $1 to both public and private sector. Again, and that's a ceiling price, meaning that if the volume goes high, the procurement agency or the procurer could always negotiate a lower price. So that's the But I guess this is already half of the export price that is existing for HIV self-test. So it's a big step towards the affordability of the self-test. But yeah, so it's reducing all the other components of the pricing would make it even further affordable.
Yeah, and as this is where public and private partnerships are very important going forward, right, Carlos?
Yes, I'd like first to ask everyone who has questions, always use the Q&A or chat so we can view. That's first. And second, I agree, Cheryl, it's a fantastic work that has to be done in order to reduce cost overall in promote access. That can be done via scale. If we do have public health programs around the world considering self-testing as part of their diagnostic mix to be offered, it doesn't have to be one or another. It has to be a combination, and use it wisely. This will leverage production and will promote cost reduction. That's very clear. And that's what we want to do. That's one. Second, and then I ask WHO to support us in that, is to review healthcare settings. For instance, Brazil in the past had only labs and hospitals in conditions and legal conditions to deploy diagnostic tests. Exception were public health programs like a family program in the Amazon and so on. All the other situations, you would need the lab to be involved, which is very clear. There is a great benefit. But we learned with COVID that it's important to have new spaces for testing in good conditions, with quality products, so on. And just for example, we are going to have one presentation today about the pharmacy system in Brazil. So we had 6,500 hospitals, 18,000 labs. We added a potential number of 88,000 pharmacies around the country, and they are close to everyone. And like pharmacies, there will be clinics, there will be medical facilities and several others. Even companies can add their efforts if well-trained and capabilities are checked. They also can be part of a pandemic workforce against this kind of problem. So these new spaces must be seen. In Brazil, currently, we are going to review the legislation for this, and it's a possible situation. So I think it's a worldwide effort to see these new spaces on a creative but safely, in a safe way, how we can add this and also promote more scale to the products.
Absolutely. I just want to go to the Q&A because we have two questions that have come in. There's one question from Ana Flavia. Carlos, I might ask you to assist with translation. And then we also have a question from Carmema asking how long do you consider that the manufacturing of self-tests could be sustained if countries do not implement public policies of testing? So maybe that's just a general question, really reflecting on, the need for the policy to really drive the demand, from that manufacturing side. I don't know, maybe Rosanna, if you want to take that one.
Yes, I think it's very important for companies to know the market size and the demand for them to maintain a production line, right? And if, judging from other epidemics like Ebola and Zika, for example, there's a feast or famine in terms of demand. Normally there's not much demand and all of a sudden huge demand. Manufacturers companies really find it very difficult to maintain a production line or reagents so that they could meet the surge in demand when they need it. So I think it's really important for us to think in terms of policy for a country or a group of countries or a region. What would be the demand for the use of self-tests in the days to come, in the months to come, and be able to inform manufacturers? Would we always need some, just like we need some maybe flu tests for healthcare workers in the next flu season, etc.? Those are what countries are starting to think about. How much longer will we need these tests, or will we now regard, when the pandemic is over, regarded as one of the common colds that we don't bother to test? And so that's a very important aspect of what needs to be done now.
Yeah. Cheryl, I agree with Rosanna, and that's a key question, especially when we don't know what is going to come next. The next wave, what is going to be, we don't know. We see a surge in Asia, lockdown in Shanghai, Korea going up, European countries also up, and Brazil thinks everything is finished. Brazil and several other countries. So what we have to do? We have to move on, and I will leave the question by Ana Flavia to find. We'll have several presentations later on, and the question is very relevant. She touches on the topic of taxes. Countries like Brazil have very high taxes on different products, including healthcare products. And sometimes we can have a global effort to decrease the impact on products that are essential. And that should be, she's asking what FIND can do, but I also challenge WHO to have this kind of discussion with the state members, at the member states, because it's really something that it doesn't make sense to charge a high tax that is going to be received by the state, who has to spend, if not on the product, on the healthcare later on to be provided to the citizens that couldn't be tested at the right time. So, yeah, I would like,
Oh, just to close out, I think, I really appreciate this time to have this discussion, and want to thank Jillian and Rosanna for the really thoughtful comments, for the questions in the Q&A. And I know we'll go into it the rest of the workshop, but maybe a good reflection here is, after working on self-testing for about a decade, these questions are very similar to me, whether it's HIV, hepatitis, STI, syphilis is where we're working to develop guidance even now at WHO. These are issues that I think are cross-cutting. And it is really important, as maybe we go through the workshop, to think about, how we push towards a broader self-care, self-testing strategy for countries. Brazil is quite a leader in HIV self-testing, and many other countries are leading on a variety of self-care and self-testing packages, and COVID might be just one of those. So very important to take that forward, and I'm excited to learn from the rest of the speakers. And thank you so much, Carlos, for assembling the group, and looking forward to the rest of the workshop.
Fantastic. Cheryl, Jillian, Rosanna, thanks a lot for your fantastic contribution, and the work is always open for you. Whenever you want to bring anything new, we are more than happy to have new sessions as well.